As many of you know, iPro is the QIN-QIO for 11 states and DC. Our website and contact information will be shared in chat. Next slide, please. Our small talk series will be held every month through June. Our targeted content will be delivered in about 20 minutes, followed by 10 minutes for discussion, questions, and ideas. Our framework for the talks is to share a challenge, offer an intervention, and guide you to a successful outcome. Information about our upcoming topics will be shared towards the end of this session. And with that, it's my pleasure to introduce our speakers for today. Kathy Calandra, a Quality Improvement Director focused on care transitions at Health-Centric Advisors, and Laura Benzel, a Project Manager and Subject Matter Expert on Health Equity at Clarent. I'm now going to turn it over to them.
Thank you, Gloria. Next slide, please. So we've known for a very long time that it's during the transitions of care from one setting to another that there are several factors that can contribute to failed discharge plans. Best practice models have addressed starting the discharge planning on admission, regardless of setting. They've stressed good communication with patients and caregivers and providers. They stress medication reconciliation, and some include follow-up phone calls. Project RED that we're going to speak of today is a model that was implemented in the acute care setting, and it's one such best practice. And today, I'll not only review that model's basic elements, but provide some information on how it was modified to also be successful in the nursing home setting. So today, the way this is organized is we'll talk about the challenge, we'll talk about the intervention being Project RED, and we'll talk about some results. Next slide, please. So I think you can guess why this matters, is that despite best efforts, things don't always go as planned. Using the evidence-based Project Re-engineered Discharge, or Project RED, adapting it even within the nursing home setting, has been proven to show a reduction in readmissions after patients were discharged. In chat, you'll have a link to a short video that is in our resource library that kind of speaks to this success when it was implemented in the nursing home environment. Next slide, please. So to sum up the challenge, patients and/or their caregivers, again, often do not have the information or the resources needed. Again, despite best efforts, people are doing their patient education, they're doing their medication reconciliation, they're handing them documents, and then again, despite all best efforts, sometimes things just don't go as planned. And the other challenge is that we're trying to prevent penalties. We know nursing homes and hospitals, for avoidable hospital readmissions, they do suffer from penalties when the discharges do not go as planned. Next slide, please. So as mentioned, there are many evidence-based interventions to improve care transitions. Most of them are focused on the transition when the patient leaves the acute care setting. Before I explain how it was modified for the nursing home setting, here's a little background on Project RED. This hospital-based care transition model coordinates the patient's discharge plan throughout the hospitalization. And then it provides a post-acute discharge guide and follow-up calls. Its components, again, have been proven to reduce rehospitalizations, and it also yields high rates of patient satisfaction. Hospitals that have implemented Project RED may also be familiar with Louise, who's their virtual patient advocate. The Project RED site has a link to the toolkit that's available by AHQR, and you'll have that link to the Project RED link information that exists in our resource library to get you there. The toolkit includes how hospitals can implement the elements of Project RED. But a study by Hebrew Senior Life which is on this slide, conducted a small pilot in Massachusetts nursing homes using the key elements of Project Red and an aftercare plan in their process. And the results of their study in the nursing homes showed a 30% lower rate of 30-day readmissions, and patients were less likely to visit the emergency room. They also saw increased PCP follow-up and patient satisfaction improved. So health-centric advisors, through a special innovation project that was awarded by CMS, further expanded the use of Project Red in nursing homes. And we were pleased to see similar outcomes. We had reductions in 30, 60, and 90-day readmissions, and also improved patient satisfaction in the nursing homes that were participating. And this is just an excerpt of some of that data that's available from the Hebrew Senior Life article. Next slide, please. So on this slide, you see the key elements of Project Red from the way it was designed for hospitals. In order to prepare them for a successful community discharge, we adapted this to the nursing home environment and added as a key element the connection with community services and support. You see the asterisk for community connections. In our special innovation project, we partnered with the Aging Service Access Point organizations, the Areas on Aging, and home health agencies were very involved in order to enhance the success of the project. The overall goal is to engage patients and their caregivers in the discharge planning process and the education using the advanced care plan, the aftercare plan. And I'll reiterate that in just a minute. The major benefit is that the individual is going home and their family member, and they're doing so with something that is easy to understand. They participate in the development of it. It's written in plain language that's not unfamiliar to them. And more importantly, it's not the first time they're seeing it. They had a role, ideally, in developing the plan. Next slide, please. So if you're in the role of discharge planning, you recognize these elements of the standard process. Begins on admission, there's engagement of the patient and the caregiver, there's setting up of services and equipment, providing written instructions as part of the discharge, and some may also include follow-up phone calls. With the implementation of Project Red in the nursing homes, those follow-up phone calls were enhanced, sometimes shifted from the social worker to the nurse case manager. And Project Red provides a script for such calls to get into a little bit more detail about what is expected, make sure the services are in place, again, repeating the medication reconciliation. So just another additional reinforcement of the plan of care. Next slide, please. So what action is needed? When Project Red discharge planning begins on admission with the first introduction of the aftercare plan, it's a key tool with elements that serve, again, to engage the patients and their caregivers. You see an excerpt of the plan that's available to be printed manually. You can see that it's large print. And again, it is meant to be completed with the patient or their assigned caregiver. As part of the aftercare plan, the patients and their caregivers are referred to, again, to long-term services and supports, along with their medical follow-up before they're discharged. And again, the key part in all of this was really connecting them to the community. The 48-hour post-discharge phone call, again, key to reinforce the education, identify any additional needs. Most of the nursing homes that participated in our innovation project did incorporate the elements of the aftercare plan into their electronic version. So some did print out the booklet to hand to the patient, but most took the elements and actually enhanced the document that was included in their medical record. And what you see as a link is to the actual aftercare plan that's in our resource library. Next slide. Another important tool when using Project Red is the re-engineered discharge for skilled nursing facilities checklist. Try to say that fast 3 times. It includes the key elements that were presented earlier. Again, the discharge plan implemented on admission. It can be used throughout the planning process, not on the final day or 2 days before discharge. It's really meant to be used as a tracker throughout the process. So the idea is that by discharge day, all elements are in place to ensure a smooth transition, particularly the connection to community services. I really can't say that enough, which may not just be the traditional home health or equipment delivery, but also services that may address other risk factors related to social determinants, such as access to food, medications, and more. Some nursing homes that participated in the project brought the checklist to their interdisciplinary meetings. So all participants had a role in ensuring that the elements were addressed and completed prior to discharge. As you can see on the excerpt on the screen, the admission assessment kicks off with determining language preferences. And then the Project Red Toolkit, I might mention, also has some tips on selecting the most appropriate caregiver or multiple caregivers as well. Next slide, please. So keys to success, as with any QI project, engaging leadership, training staff, developing champions are all keys. In order to know if what we're doing is working, we always advocate for tracking and assessing results. One of the simplest ways to do this is just to measure the process. With Project Red in the nursing homes, the idea is not to redesign a program, but to build efficiency and best practices into the existing processes. Interdisciplinary planning meetings are not a new concept, but connecting with the community providers such as the VNA or the areas on aging early on, and even including them in the process, we saw really positively impacted the outcome. Next slide, please. So just some quick suggestions on measuring your quality improvement if you should adapt this model. It can be as simple as checking whether or not a tool such as the aftercare plan checklist was implemented, or one key element of the process can be monitored, such as was there a post-discharge 48-hour phone call implemented. So of course, all of this may look simple at first glance, but we acknowledge when you're doing person-centered care, other considerations need to be taken into account. So that's my cue. I'm really excited to hand this over now to Laura Benzel. Laura?
Thanks, Kathy. It's great to be here, everyone. Next slide, please. So as Kathy mentioned, the adapted Project Red toolkit adds a key element, and that's community connection. Community connection is an important component for addressing social determinants of health. So just to make sure we're all on the same page, I'm going to share a definition that we use from Healthy People 2030. Healthy People 2030 definition for social determinants of health is the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Healthy People groups social determinants of health into the 5 domains you see here listed on this graphic. So increasingly, we are recognizing that addressing social determinants of health is essential to reducing the health disparities that are often rooted in social and economic disadvantage. In fact, non-medical determinants of health are believed to account for up to 60 to 80% of health outcomes, which is why we discuss them so often. Next slide, please. So studies have shown that social determinants of health, such as those that you see highlighted on this graphic, are risk factors for increased hospital admission and readmission. Some of those readmissions, of course, are unavoidable, but some are potentially due to unaddressed social risk factors and could potentially be prevented. Consider that studies have shown that social determinants are better indicators of hospital readmission than standard care. A best practice to reduce readmissions and improve health outcomes is to systematically screen for social risk factors. When screening for them in a standardized process, it allows us to remove assumptions about what we may think we know about our patients and offer them the context to share. Some individuals may be hesitant to discuss their social challenges. There is some stigma around that. So building trust and approaching it as a routine part of the care can relieve that discomfort. There are many social determinant screening tools available at no cost that you can use as is. They're all downloadable from the internet. You can also use them to help design your own. We have some listed on a resource page that I'll be discussing in a moment. I should also mention that many electronic health record systems now are integrating social risk factor screening tools into their systems. After screening for social risk factors, you can become a reliable resource and support patients throughout the discharge process by making the connections to community-based support services and resources that address these risk factors, and you want to do that before the patient is discharged. There is solid evidence that addressing social determinants is effective. For example, a recent Commonwealth Fund report shows that among the 11 wealthiest countries, unfortunately, the US spends far more, but we rank last overall. And the report outlines 4 factors that distinguish those top performing countries from the US, and one is investment in social services, which far exceeds our country. Next slide, please. So as a health equity advocate, I take every opportunity I can to talk about culturally and linguistically competent care. And that is the ability to successfully communicate and provide care to patients with diverse backgrounds, beliefs, and values. It should be employed by all members of an organization at every point of contact. A culturally and linguistically competent approach to care ensures the effective delivery of care to all patients, especially those with limited English proficiency or those with lower health literacy. And additionally, it promotes health equity. Providing culturally and linguistically competent care builds trust and understanding with patients. It improves communication. It reduces patient safety events. It helps minimize unconscious biases and stereotypes that we may harbor, and it improves healthcare quality and outcomes. The national class standards are an excellent starting point if you want to learn more about this. Class standards are services that are respectful of and responsive to patients' individual needs, again, a key component of health equity, and as I mentioned, employed by all members of an organization. Next slide, please. So this is the resource page that I was speaking about earlier. You can see the first 2 on the left-hand side are the video that Kathy mentioned, as well as implementation tools. I've included a resource from the CMS Office of Minority Health, a guide to reducing disparities in readmission. And then there are several resources with social determinants of health screening tools. All of these resources have websites, they have implementation toolkits, and a lot of supports to help you if you're starting on the journey for screening for social determinants of health. Next slide, please. So although this session was focused on care transitions, we would be remiss if we didn't take an opportunity to talk about COVID and immunization. We know this is on the forefront for you and your teams at this time. Boosters are critically important to help slow the spread and reduce the risk of hospital admissions. This slide includes key points in support of boosters that you can use with your teams, residents, and families. Over the next few months, we will be offering additional support, including education, tools, and resources for you and your teams on boosters. Please feel free to reach out to us with any needs and any successful strategies that we can share with others. I'll now hand it back to Gloria.
Thank you, Laura. Next slide, please. Here's the contact information for Kathy and Laura. Next slide, please. Kathy and Laura, thank you so much for that excellent presentation and for that important reminder about boosters. Now it's time for our Q&A session. Please share any questions, ideas, strategies that you've tried or lessons that you've learned in chat, or feel free to take yourself off mute to ask a question. Janet, do we have any questions in chat?
Not at, well, we do have one. I'm sorry. So for Kathy, from your own experience, if a facility could implement one tool to get started, which one would you recommend?
The best idea would be to take a look, and again, these are available in our resource library, at the checklist. Reviewing that can kind of be compared to what their current process is in setting up discharge plans, and they might find some, elements that they're not doing, and then they might readily be able to bring that to their next interdisciplinary meeting and kind of go through it and get people in the practice of everyone participating in setting up all elements of a successful plan. And then the other thing, I would do the same thing with the aftercare plan. Take a look at it, the project re-engineer discharge plan, compare it to what is spitting out of their own electronic records, if that's what they're using, and see what's missing. And see, more importantly, if the language can be modified to be more user-friendly, to be more easily understood. So that would be the first thing I would do, I think.
Does anyone else have any questions? Janet, do we have anything else?
Yes, there's one more.
Right.
Laura, this is for you. Getting started, especially now, can be a challenge. What do you suggest providers do as a first step to get started on addressing social determinants of health?
It's a really great question. And the first step I always recommend is to make those community connections, as we talked about today. Obviously, when you screen for social determinant of health and you identify one, you want to be ready to address it for the patient. So it's important to make those community connections and have a library of resources, for example, for food insecurity, homelessness, helping with purchasing medications. Have that database of resources available so that when you identify a social risk factor, you're ready to go and you can help address it for the patient.
Excellent question. Thank you. Any other questions? Anyone will have a success that they'd like to share? Or something that they've tried? Feel free to take yourself off mute. All right. Well, next slide then. So thank you for those great questions. We want to remind you about some general tips for success. Being sure to identify a champion to take the lead on the project. Start with small steps of change, then evaluate and adjust as needed. Next slide, please. We're here to support you, and we encourage you to reach out with questions or needs. You can find our contact information through our website, and please contact us. Next slide, please. Your feedback is important to us. Please fill out our brief evaluation form, which will be sent to all registered attendees. Feel free to include what other topics may be of value to you for this series. Thank you for that. Next slide, please. We hope that you'll be able to join us for our upcoming small talks. The link to the event page will be found in chat. Our weekly educational small talks are designed to address the challenges you've shared with us. Also, please join in our monthly office hours for peer-to-peer support. And the link for that is above in our slide. Next slide, please. And finally, and most importantly, thank you for all you do. Stay safe and have a good afternoon, everyone.